Thank you for coming tonight, guys. We are recording this, and this is a new venture for the RMD program and the RETAC. What we're trying to do is begin a program whereby we can record all educational trainings, whether they be given by a medical director or a service director or any one of you guys that has an interesting topic that you want to present. We're trying to develop a format where we can record that, have it posted on the SLV RETAC website, where it can be accessed under the Education tab, and then it could be seen and viewed by those of you who might not be able to make a meeting. It could also be seen and viewed by those of you who are in another service. And so we're hoping to make it available to everybody within the RETAC, and ultimately I think the dream is to be able to even receive CEs for it. Dr. McDougall's working on a program, and he may come up after our presentation and explain that a little bit, whereby we could have somebody remote review this, or view it, say from another service, say from Monty or Costilla, at their leisure, answer a set of questions or something to document that they actually did see the deal, turn it in, and get CEs for it. And so yeah, we're going to develop an archive of educational materials that's kind of homegrown, try to get credit for it, try to preserve some of what we're doing, and that's why we're doing this tonight. So along those lines, Tyler and I had talked a little bit and decided that we wanted to do a presentation on a refresher for CPAP, being a super useful procedure, but one that's not done every single day. We thought we could review it and also review how we actually hook the equipment together after we talk a little bit about the policy itself. So CPAP is acronym for continuous positive airway pressure, and we use it in addressing issues with respiratory failure. Respiratory failure, real briefly, guys, as you know, is just basically a clinical state that we describe when somebody has a failure of oxygenation or ventilation, or frequently both. We talk about people in respiratory distress. I think there's kind of a large gray zone between respiratory distress and respiratory failure, but many times my observation has been people that we describe frequently as being in respiratory distress, marked or severe, are actually at that time even already in respiratory failure. Some of the things that we see clinically with respiratory failure: rapid breathing. Early on, of course, you know, if you're in respiratory failure, you're going to breathe faster to try to compensate for it. But as things go downhill, you can't keep up. Your respiratory rate comes down to normal and then gets slow. Same thing with heart rate. Heart rate may go up early on, but as things start to go down the tubes, it'll slow down, and you'll find people that are more bradycardic. And of course, the end game is no heart rate at all or no breathing at all. Increased, decreased, or no respiratory effort. Again, along this kind of a bimodal plane, where at first, in early respiratory failure, people are working super hard, but as they tire, they work less hard, so there's decreased respiratory effort. Or if the reason for respiratory failure is CNS, that's the reason for the respiratory failure, and ultimately no respiratory failure. Cyanosis can be a sign, altered mental state, when perfusion gets to be so bad that the brain isn't perfused. We talked about respiratory failure involving a failure of oxygenation and ventilation. Just a reminder here, we have two things that we really like to measure. One is pulse oximetry, which is really the measure that we use for oxygenation. Our other, importantly and more recently, but not terribly recently in years, is CAPNO. And this is why we so highly emphasize this in any respiratory distress / failure person, because that's how we measure ventilation. So our pulse ox, which we've historically used for everything, that's for oxygen. CAPNO's for ventilation. Positive pressure ventilation is our standard intervention when people are not breathing well enough or are hypoxic, especially if it's for ventilatory needs. And what we're talking about when we talk about positive pressure ventilation is just something that pushes air into the chest. So it's a positive pressure intervention, and it overcomes any airway resistance. When we use a bag mask valve device, that's positive pressure ventilation, but it's only positive pressure while we're squeezing the bag. As soon as we release the bag, then there's no pressure. So that's an intermittent positive pressure ventilation designed to augment the pressure of ventilation during inspiration, but allow expiration to occur against no additional pressure. When you're bagging somebody on an I-gel or on an ET tube, it's the same scenario as it would be with a bag mask valve device. Again, only pressure intermittently during inspiration, but not during expiration. Where CPAP is different, continuous positive airway pressure, is that it's continuous positive airway pressure during inspiration, just like you are when you're pushing the bag, but during expiration, the CPAP device is applying a little bit of positive airway pressure during that part of the cycle as well. So you've got augmentation of positive pressure with inspiration. You've got expiration actually occurring against a little bit of positive pressure. We're going to talk in just a moment why that works and why it's so important. So the beauty of CPAP, by keeping the positive pressure throughout the entire ventilatory cycle, it allows the alveoli to not collapse as much at the end of exhalation. Normally we breathe in, the alveoli fill up with oxygen. If we breathe out, they tend to collapse a little bit. If we're healthy, they don't collapse all the way. But in respiratory diseases that cause respiratory distress, pneumonia, COPD, chronic bronchitis, emphysema, congestive heart failure with pulmonary edema, on all of those alveoli are trying to collapse at the end of expiration. And this positive airway pressure during expiration, it helps prevent that collapse because it doesn't let them empty all the way, if that makes sense. So what it does by maintaining the level of a constant level of airway pressure is it keeps the alveoli open, and it also forces any fluid that might have accumulated in the interstitial spaces and in the alveoli of the lungs by virtue of that positive pressure that's in there, kind of forces it back into the vasculature. And in so doing, improves gas exchange, and that buys some time for us to do all the interventions that might work. So increasing alveolar surface area is a big plus, helps increase oxygen diffusion across the membranes, and ultimately reducing the work of breathing. And that's kind of what we're all about. This is a super, super valuable tool, and I think that's one of the take-home points that we wanted to get to you today by getting this stuff out and letting you feel comfortable using it. It can reduce the likelihood of your patient becoming intubated a lot, and it can reduce the likelihood of dying by a lot, 30 and 20% respectively in this Annals Emergency Medicine article in '08. So super, super helpful, and it's so helpful that it's one of the primary interventions. Now in a minute we're going to show you our protocols for CHF and pulmonary edema, for wheezing, and for respiratory failure, and you'll see CPAP is in all of those. It's high on the list of things that we need to be doing first. So if somebody's in severe respiratory distress and or respiratory failure, again, sometimes they're in both simultaneously. Accessory muscle use, if the answer is yes, that's severe. Persistent hypoxia despite aggressive oxygen, then you might think of CPAP. Marked increase of work of breathing, yes, think of CPAP. Inability to speak full sentences, another thing to think about. This is on the indications list. Contraindications, there are some things that we're going to talk about in a moment when we go to our own protocols that will tell us when we shouldn't reach for the CPAP, but they're relatively limited. In general, generically, the reason that we talk about respiratory rate being a contraindication if they're not breathing much, this is something that, unlike a bag valve mask ventilation where you can actually assist or augment their rates, this is something where they have to be breathing on their own. they're going to be breathing and getting supplemental pressure to their airway and pressure support to their airway. But if they don't have a satisfactory respiratory rate, it's all to no avail. So if we have a respiratory rate of less than 10, it's not going to do much good. Systolic blood pressure is important. If a person is already hypotensive, positive pressure ventilation throughout the expiratory cycle can make people a little bit more hypotensive. And that's because of increased pulmonary vascular and intrathoracic pressures throughout the respiratory cycle. It will not help systolic blood pressure. So I think the convention is 100 millimeters of mercury systolic or less. Probably do not add your CPAP. Confusion, not because confusion is a bad thing to have for CPAP, but because the presence of confusion or an inability to understand or cooperate will limit their ability to use CPAP. You have to have a patient that's alert enough to work with you to use this mask that has pressure flowing that isn't really comfortable initially. When you first put it on them, they may not feel like it's helping them. So we have to be able to work with them and talk them through that, and we're going to do some demonstrations about that tonight. It's super important. Recent pneumothorax, again, for the same reason that it might lower blood pressure because of changing your intrathoracic pressures. If you had a little bleb that was ready to break as a pneumothorax, or you had a pneumothorax last week, it would not be a great thing. Nausea or vomiting is a relative contraindication because, as you'll see in a minute, this mask is going to be strapped tightly over their face. Need to say, and so that could be a difficult problem. So, what does our procedure say for CPAP? They also go through indications, and this is real important to pay attention to because it will tell you here what the reasons are to use CPAP. So if you have a respiratory distress patient that's symptomatic, moderate to severe category, and you need 2 of the following things, but only 2. You may have all, but just remember you need to have only 2 of these. So rales, rhonchi, or wheezes. Don't have to have rales specifically. Rales are ideal, but if you have rales, rhonchi, or wheezes, that might be a CPAP candidate. If you have dyspnea with hypoxia, even though you're giving oxygen, you may be giving 15-liter non-rebreather, or you may be giving 4 to 6 liters nasal prong. But if they're still hypoxic with an SpO2 of 90 or less, despite your supplemental oxygen, it's kind of like, what else am I going to do? I'm going to think about CPAP. Dyspnea with inability to speak full sentences. That's just telling you that they're pretty dang dyspneic. Accessory muscle use, again, speaks for itself. Respiratory rate greater than 24 on O2. Okay, so maybe they're really tachypnic at the scene. You give them oxygen. Maybe they're up to 90 or 91 or 92, but they're still huffing and puffing and huffing and puffing. Diminished tidal volume is last because it's very difficult to know exactly, but when we talk about tidal volume, it's just how much air are they moving. And that's a subjective perception, but you can get pretty good at it after you've seen a lot of people in respiratory distress. So once again, any 2 of these, you don't necessarily, the one that we default to the most often is hypoxia despite supplemental oxygen. And just remember that that's not the only one, if you have any of these other indicators. Contraindications, very similar to what was mentioned in the previous slide. Respiratory arrest, if they're not breathing, it's not going to work. Cardiac arrest, if they have no perfusion, it's not going to work. In our protocols, I think we've decided a systolic blood pressure not less than 100 but less than 90 would be a contraindication. Lack of airway protective reflexes. Too altered to follow verbal commands or cooperate. Vomiting or active upper GI bleed with vomiting. Suspected pneumo. Trauma. Most respiratory distress and trauma is because of a pneumo or something like that, or intrathoracic bleed or something. Not really going to be a good candidate for CPAP. And if their size or anatomy prevents adequate mask seal. The technique we're going to review here in just a second. Tyler's going to show us how to do this. You'll note that this has got to be an awake cooperative patient once again. So generally, the respiratory distress patient that's awake and cooperative, we're going to have them in a seated position or at least a semi-Fowler's position. So you're going to work with them in that position. You got to get a full set of vitals, and in this case, a full set of vitals for sure also includes capno, as it does for every respiratory distress patient. Apply the CPAP mask secure with straps. We're going to show you a little bit how to do that. There's an art to that. Operate according to specs. Tyler's going to show us what we're using here. We want to start with the lowest continuous pressure that appears to be effective. So the unit that we're using here has a 5, 7.5, and 10 CPAP. So we'll start at the lowest of those, which is 5 centimeters of water. So you always start low and then work up. Monitor continuously. Check to see if they're getting better or getting worse. If they're getting better, they should have less work of breathing, stabilized blood pressure, improved SATs, things that all you would recognize. If they're getting worse, it would be just the opposite. SATs not getting better, capnos may be getting worse, work of breathing or mentation not improving. What do we do if they deteriorate on CPAP? Just the same thing that we would do if there was deterioration with any of our equipment. Check our equipment first. So check all the circuits, check all the connections, be sure that we're in good shape. Consider the next step, which would be a more invasive airway, either a supraglottic or an invasive endotracheal airway. Think about, did we cause a pneumo with this temporary positive pressure, and are they getting worse because of a pneumothorax? And check for blood pressure to make sure that they're not getting worse because of the positive pressure. At the bottom, the CPAP devices that we use here do have a variable FiO2, and Tyler and I are going to show you how that works and how to adjust it and when to adjust it. So that's it on the background stuff. Are there any questions on this? And if it seems pretty straightforward, we'll get to the equipment. Tyler, can you help us out?
Okay, so when you pull this device out of the bag, it's pre-assembled. It's going to come with everything necessary in the bag. Many of these even come with a nebulizer in the bag as well, so you don't need to go digging for a nebulizer if you end up needing a nebulizer. That comes in the bag. Not necessarily all these parts. This is a fully assembled nebulizer from another kit, but you will get the nebulizer chamber, the T, and the stuff you will need to hook it up to the CPAP machine itself. But it's going to come out of the bag. It's going to be fully assembled. Do be aware that this particular company has at least 30 different versions of this. Sometimes just because of stocking issues, it's hard for me to get the same ones every time, but they are all generally the same. Most of the time when I'm doing ordering, I'm looking for one that we can select the FiO2. It comes out of the bag set at 30. So this end is going to hook into your oxygen supply, whether that be a portable oxygen supply, like on a bottle. The key factor here is if you use a portable oxygen supply, it is going to have to be a regulator with a high pressure port. You cannot hook it up to your regulated port. That will not supply enough pressure to actually operate the device. So you're going to be looking for this threaded piece on the side of the regulator. Make sure you grab a regulator with that. If you're on house oxygen in the ambulance, you can hook this straight into, I didn't bring it up here, but the OMEDA connection on the wall port. Also, most of our wall ports have both the regulated and a high pressure hanging right off the bottom of them. So most of the time, you don't even have to change anything on the wall of the ambulance. You just screw this on there to the high pressure port, whether it be on your portable device or in the rig.
So there's 2 high pressure ports on this regulator, either one.
Either one. Yep.
Okay, right.
Yep.
So yeah, super, super critical. And especially if you're in the rig, don't be tempted to use the one that goes through the regulator.
And
Use high flow, high pressure.
it'll be somewhat difficult to make that mistake. I mean, this is rigid plastic, so it's not going to want to go on that little barb connection, but I suppose it could be a mistake that was made. So just know that this has got to be hooked to the high pressure. So out of the bag, it's coming set at 30 FiO2. So the way this particular system works is you're getting 15 liters per minute of oxygen at pressure. So it's different than 15 liters a minute out of the regulator port. This is 15 liters a minute, but no pressure behind it. This is going to be 15 liters a minute with pressure. It's going to pass through this valve that will regulate it to the 30 FiO2. Speaking of which, does anybody recall what FiO2 stands for? Think on that for a little bit. We'll come back to it. So as that 15 liters a minute passes through here, it's also going to pick up another 125. That's a lot. 125 liters a minute through this filtered port. So that you're going to end up with 140 liters a minute actually traveling through this. Okay?
This is what generates the pressure. It's keeping those airways open throughout the whole inspiratory cycle, in addition to the atmospheric pressure that's in our room.
A unique feature of this particular brand is that the intake for the room, the atmospheric air, is also a HEPA filter. So if you have a patient that's obviously already in respiratory distress and nearing failure, you don't want to introduce any other contaminants or allergens or anything like that. So that is an advantage that you are giving the patient clean air, 100%. So that 140 liters a minute travels through this tube. This tube can be expanded, worked around as necessary. Comes up into this. There is a little orange valve in here. This orange valve allows, say your oxygen bottle ran out and you weren't paying really close attention. You don't want the patient to be locked into this mask and then all of a sudden run out of air and not have any air to breathe. So while this device is in operation, the pressure will close that valve and keep this device sealed from the outside air. If for some reason you run out of house oxygen or the bottle and this device shuts down, that valve would fall open and allow them to breathe atmospheric air in so that you're not asphyxiating your patient. So it travels up into here. In this configuration right now, it's going to travel through a HEPA filter. Again, this will also be a two-way filter because you're going to be filtering both of the inhalation and the exhalation. This is this particular setup. The other versions of this, the newer versions of this, the HEPA filter is actually right underneath this PEEP valve. And that is actually what you're going to see on the ambulance. This is an older training one. But the one on the ambulance will have the HEPA filter right underneath the PEEP valve, which makes this whole operation a little bit smaller. That's a new advantage. So either way, you're going to get filtered inhalation and exhalation. So when you're doing this operation and creating those aerosols, especially with any kind of like a COVID patient, there's a safety factor there for us. The out-of-the-box PEEP pressure is going to be set at 5. You can set it to 5, 7.5, or 10, and you do that by just turning this. And there's an audible and a tactile click that you can feel. And you'll also see that the 5 will get covered up, and then you can only see the 7.5. That indicates that you're right there. If for some reason maybe you did make a mistake and you didn't get quite to the click, it's not too big a deal. The manufacturer says that if you are at least within a little bit of that rotation, and if you didn't make it all the way to click, you're still going to be plus or minus about 0.5, so you're still within therapeutic range. So it's going to start at the 5. You can go all the way down to 10. Of course, we start at the lowest setting and see how the patient tolerates it and see how their condition improves or doesn't improve, and then modify those settings accordingly.
So Tyler, you've mentioned a couple of times and called this a PEEP valve. And I want to see if you guys know what a PEEP valve is and what we're talking about when we mention a PEEP valve. So a PEEP valve is another acronym, and it's for positive end expiratory pressure, PEEP. And when we talk about that valve, that's going to be also, since the pressure at the end of expiration is going to be the amount of pressure that we administer with this CPAP device throughout the entire respiratory cycle of inspiration and expiration, that's the amount of pressure that we're supporting ventilations with. So that PEEP valve at 5 is at, meaning 5 centimeters of water of pressure. So not a lot of pressure, but we'll start at 5. That's how much pressure we're having to augment inspiration and to breathe against during expiration. And as Tyler said, we always start at the lowest and work up depending on the patient's response.
So going back, since we covered PEEP acronym, what's the FiO2 acronym? What does that stand for? Fraction of inspired oxygen, yes. So that at the 30 setting, I said 15 liters a minute, 125, a total of 140. That's at 30. So that means we are taking, what is our normal atmospheric oxygen? 21%. So at a 30 setting, we are delivering to the patient a fractional oxygen of 30% instead of 21% that we would normally be used to. Okay? This has just 3 settings, a 30, a 60, and a 90. Again, start at the low end, and we're going to work up as the patient needs. One note about both these valves. So if you change the FiO2, if you choose to go from a 30 to a 60 or to a 90, and you are on a portable bottle, you better be real close to wherever you're going to get onto some house oxygen. Or if you're even on house oxygen, you better be not too far from the hospital. This thing will burn through even big K bottles real fast, real fast. So if you happen to get on the ambulance that day and there was 1,000 PSI on a K bottle, which definitely can happen any day, right? And we're 20 miles from the hospital, and you're at a 90 on this thing, you're going to be emptied long before you're there. So just know that in your management. I think Hurley would agree that it is better to keep some pressure for the whole duration than overdo it on the FiO2 and have the last 5 minutes of the transport no pressure. So just be cautious of this valve. On the flip side, the way this particular unit functions, some units, if you change the PEEP pressure, it will change the demand of the amount of flow it's using out of the bottle. This particular system does not. So if you choose to change the PEEP pressure, you will not change the consumption of the oxygen. So just know that. I would, with this system anyway, I would definitely max this out before you start considering this.
And along those lines, I've been asked frequently, when we talk about one of the primary reasons that we're going to go to CPAP is because we've got your non-rebreather and you've dialed it all the way up to 15 liters, which is how many percentage, what's the percent FiO2 with a 15-liter non-rebreather? What would you guys say that is?
90.
Probably 90, maybe 88, 90, something like that. So if you're giving that non-rebreather at 15 liters, you've been giving them 90% of inhaled oxygen. And now, since it's not working, you're going to take them off of that 90% and put them back on 30%. That's not a mistake. That speaks to the value of positive pressure support on the airway. So yes, you're taking them from the 15-liter non-rebreather, which may be giving close to 90%, give or take a few percent, and taking them and putting them to the preset rate of 30% for starters, because that's what our protocol says to do. That's not a mistake, and they generally will not crash. Now at first, they're going to feel different, but that's mainly because of the pressure that we're having to coach them through. So the pressure is so important ultimately that it can make up for a drastic diminishment in FiO2. That's not to say that your patient may not get sicker and require 60 or 90%. Tyler, let's show them how we can coach people through this.
Sure.
Maybe with a real person or something.
Get a volunteer.
My lungs have been cramped for 30 years.
Okay.
So when you pull this mask out of the bag, it's going to be in this configuration. It will be attached to the top, already Velcroed down, and it will not be attached to the back. It's got this forehead piece that you don't want to put that in their eyes, obviously. So you're going to want to get that up on the forehead to help stabilize this whole thing. I think this is a medium size. It's probably going to be a little small for him, but you're going to want to get the appropriate size mask. I would say he'd probably be a regular adult, so that you get a good seal and you're not trying to work around. If we're doing this, you probably got your patient on, say, 15 liters non-rebreather. So they're on a mask already. You're going to want to start coaching them, telling them, okay, we're going to change you. We're going to put you on a different mask, but this one's going to be a little different because it's going to be strapped to your head. It might feel claustrophobic, but I guarantee you that it is supplying way more air, 140 liters a minute, way more air than anybody can ever breathe. Okay, what's a typical person breathe? Anybody know? Around 30 liters a minute. So you can see how far beyond we are from a typical air demand. So coach them through. This can be quite claustrophobic if they've not ever done this before. What we're going to do, though, before we hook any of this up is make sure that we're flowing. We don't want to put this on the patient's face unless there is air flowing. Okay, 2 reasons. 1, we don't want to take them off the non-rebreather and then be fiddling around for 30 seconds to a minute or more getting this thing all hooked up and we're not giving the patient any oxygen. 2, you don't want to induce more claustrophobia because then they're having to breathe the dead air space through this tube, through that release valve. So we want to be supplying that air before we put this on their face. So be talking to them, get this thing all hooked up, have everything ready. I'm not going to do this because this is quite noisy when you actually hook this up, but hook this up, turn your bottle on. It will make a lot of noise. You might even want to tell your patient before you screw this on there that this thing's going to be kind of noisy because it is quite a rush of air going on. So hook that up. Once you have that all hooked up, you've verified your settings. You're at 30 to start with, and we're at 5 PEEP pressure. Then we're going to coach our patient, and we're going to start by placing the forehead of the mask on there. It's even good if the patient is willing, just hand them this thing. You just manage the straps. I'll go ahead and hand this to you, and I'm going to coach you through it because if they feel like they're in control of what's on their face, it's going to be a lot smoother process than if you put it on them. Same goes with anything we do. A non-rebreather mask, same thing. If the patient can tolerate, man, just hand it to them. Let them put them on themselves.
No, tell the patient it's okay. Take it off, put it back on until you get used to it. It may take a second, and that won't hurt. But encouraging and coaching, pretty soon, within just seconds, generally, we'll find out. Okay, it's really not so bad. But the idea is to cause a complete tight seal there, and they can do that with their own end pressure. And then once they're comfortable with that, then as we coach them, we can watch their parameters. What are we going to be monitoring on our patient, Tyler, as we do this, as far as to see how they're tolerating it?
You mean as far as vitals?
Yes. What kind of things are we going to be looking at to see if he's doing better with CPAP or not doing better with CPAP?
Well, in general, when we start, my most concern is, are we tolerating the device itself? So I'm going to be looking for any signs of panic or, are they getting agitated or anything like that? And if we need to reevaluate or go back to the non-rebreather for a period of time and try to work into this. Once we've established this and the patient's pretty comfortable, then we're going to start looking back towards the vital signs and the overall patient condition, if they had signs of cyanosis or something like that, or, what were we seeing to initiate the CPAP? Are those things getting better? So you can kind of see on Tyler's face here that medium is definitely not quite. In a pinch, it's going to work. We're sealing. I can see, it's covering up his nose. How does it feel to you? It's small, but it's sealing. So, if you had nothing else, it might do, but a bigger mask for this patient would be better.
And what size is this Colodyne mask? Do they come in? Are we a small adult, large adult?
Yeah, so this is the medium, I believe, and then there's, I think, just an adult and then a large adult. if I remember correctly. So once they're tolerating that, you pull the headgear down behind their head. You can adjust these upper straps in a minute, but I would get these hooked up first, and they just snap on right here on the sides, just like that. And it's all Velcro, so you can move these around. I'm going to snap those on. And then we need it to be snug. We want this thing to seal, but don't get carried away. And communicate with your patient. I mean, how does that feel? And the patient should be able to tell you, and you can feel too, if you're blowing a whole lot of air out around, two things are going to happen. One, you're not providing the pressure that you're intending, and two, you're going to go through a whole lot more air. If you let it leak around the mask, you are going to burn through air 2, 3, 4 times as fast. So do make sure that that's tight enough that you're getting a seal. Don't overdo it. Does that feel good right there?
So Tyler made a real important point. A lot of this, as you can see, is working with the patient to get them to be used to it. You can take it off, put it back on, take it off. You might even have to go back to the non-rebreather. But it's a therapeutic intervention. It's not just to make them feel better. Ideally, it's great if they feel better because that means they're getting better. But this is a therapeutic intervention that actually is making them better. And that's part of the coaching that you can. And actually, even though it's a really noisy unit, and maybe we'll turn it on for a minute so that we can hear it, in a strange way, I think that's even kind of therapeutic because they can feel how much air is moving around here, and psychologically, it's like, gosh, we're getting a lot of air. And if you're air hungry, that is a good feeling, you know. So, yeah, let's see what that looks like.
So, normal procedure here. Put your regulator on your bottle. Tighten it down, just thumb tight. It's got an O-ring, don't have to get crazy. Verify your gauge, do all your normal checks, make sure you're not leaking here. Turn your bottle on. These high pressure ports, if you look in the bottom of them, have a little gold or silver piece that's poking out there. That's actually a valve. So as soon as you start to screw this in there, it's actually going to push on that valve and start to release the air. So unlike the regulated port where you actually adjust the flow, these are set. They are going to release the full pressure. Well, it's not the full pressure of the bottle. I mean, we're at 2,000 PSI in here. It's still a regulated pressure, but it's a much higher pressure than this is. So as soon as you screw this on and it's down tight, it's going to press that. And so you can hear, I mean, it's definitely got some sound. You do want to keep this open because if you guys can hear, this is definitely sucking a lot of air in. So make sure that this area stays clear. And you can see that orange valve is closed. Tighter up here. And you can, if you're counting respirations, this thing makes it super easy. All you got to do is watch that little PEEP valve. When it goes up, they're breathing out. And of course, you can watch the fog in there as well.
So Tyler, remind me, these will be hooked up with the HEPA filter in line as they come out of the package here?
Yes and no. So the other ones will actually be over here, so you won't even have to deal with it.
So this is CPAP by itself, and again, to titrate the pressures up, you use this knob to titrate the FiO2s up. You would do that. I would slowly increase the pressures before you increase the FiO2s for the reasons Tyler mentioned. I think I would get up to 7.5 and 30, and then depending on patient status and difficulty in weight and difficulty with tolerating this too, because it's not the FiO2 that makes this difficult to tolerate, it's the pressure. And maybe afterward, if you guys want to come and see what it's like, you'll see for yourself. The CPAP can be used just as we demonstrated by itself. If a person with CPAP also has a lot of evidence of airway obstruction as evidence of freezing or something, show us how you might hook up a neb treatment if you decide you want to get a neb treatment to the CPAP patient.
Sure. So just a quick review on the nebs. Again, it's an aerosolizing procedure as well. So if you're doing a regular neb treatment, make sure that you've got your HEPA filter on there. If you're doing it in this manner, if you're hooking it to the mask, you can do the same thing. Just make sure that you've got that, wherever the air is coming out, that you've got that HEPA filter on there. Since we're not using that stuff. So one thing you're going to want to make sure of, the nebulizer that comes with the kit is a little bit special. It's got this blue port on the side, which is a little different than our regular nebulizers. They don't have that blue port. The reason for that blue port is so that once we're all hooked up and everything's under pressure, if you need to add more medication, if you unscrew this while this whole system is under pressure, you're going to start losing all your pressure out the bottom of the nebulizer. So the advantage of the nebulizer with the little blue port is that you can, it's got a slit pre-cut into it, and it's kind of like the top of a vial. Works the same way, only it's designed to interface with your typical albuterol or duo neb, and you just can shove it in there and then squirt your medication straight in there without having to. So you can see now I've got my meds in there. Of course, that wasn't enough. This is one of the albuterol treatments. It's only in the 0.5 milliliters, so what do we got to add to it? We need another 2 milliliters because this was a higher concentrated dose. The more recent ones that we got in, this was when we kind of had an albuterol shortage, and these were what I could get. But the new ones that we've got on the rig, we were able to get the correct liquid amount. But in this, you can still take a syringe, and the tip of the syringe can poke into there the same way, and you can add your 2 milliliters in there. So you can do that while the whole system is under pressure. So to add this into the system, you need the nebulizer to be close to the patient. On the other side of the filter, you don't want to put the nebulizer on the back side of the filter, otherwise you're going to filter all your medication. So you got to make sure that it's on this side with this particular setup. With the other CPAPs that the HEPA filter is right underneath the PEEP valve, you won't need to do this. You can actually put the nebulizer straight into the nebulizer port because the filter will be up here and you won't filter your medication. So that's just a nuance of this particular setup, is that you're going to have to add it on the other side. Makes this particular setup a little more cumbersome, which is why they're now different and the filters up here on the PEEP. But then same procedure, you keep your CPAP running, and then you can start your nebulizer treatment from another oxygen source. And what do we run that at? 6. Okay. If you go much over 6, it's not going to work. Any questions there?
How about cap note, Tyler?
Cap note, same thing. I didn't grab a cap note, but all these little parts are universal, and the cap note is pretty much looks identical to this little piece. It's going to have your kind of male and female side. You can add that into there, and then just run your sampling line back to your monitor. Make sure that you actually turn the cap note on so that it starts that pump on the monitor.
Super important. So if we're going to be, trying to assess our patient with this, we need to have that cap note on because that's going to be one of those things. Where would you put that in line in the whole sequence of events?
As close to the patient as you can get it. Exactly. So on this side right there. So pretty much where this was, if this was a cap note.
So this would be the cap note thing with the little wire coming out of it, but right next to the mask, essentially. This is really for CPAP helps individuals whose pathology, whose pulmonary pathology is primarily obstructive. And obstructive meaning that these airways are kind of collapsing or shrinking down. And of course, asthmatics know that that's one of the main things that happens to them is that their airways are shrinking down because of spasm and because of but COPD, both chronic bronchitis and emphysema, That's the underlying pathology. Congestive heart failure with pulmonary edema because of the CHF is the other one where you're going to use it. So virtually any of your old patients that have chronic cardiopulmonary conditions that are deteriorating, it's going to be helpful. That's not to say that one of those might not be a long-time chronic lung or a long-time congestive heart failure patient with a history of prior episodes of pulmonary edema. They can get pneumonia, and maybe pneumonia is the main thing that's making them sick right now. We're not going to hurt the pneumonia patient with CPAP, so I don't want you to be fearful in thinking about CPAP that, oh, I'm kind of afraid to use it because I might give it to the wrong person. I think if you take anyone with chronic cardiopulmonary disease that is having an exacerbation, even though it might be in this case that they blew a small pneumothorax or that they have a pneumonia, that you need to be aware of those and think about those things in your careful assessment, but don't let the thought that it could be that deter you from using it, because the vast majority of the time it's going to be something that is going to be your primary therapeutic agent. Our congestive heart failure with pulmonary edema algorithm indicates that nitrates still are the first pharmacologic intervention of choice, and a couple boxes down it goes to CPAP. But I think most of us would argue that CPAP would be what we would reach for before nitrates. And I think we'll see that protocol changing, I'm hoping. So CHF with pulmonary edema, absolutely CPAP. That's your primary avenue of help. Exacerbation COPD, super, super helpful. Exacerbation asthma, super, super helpful. Try not to give it to a trauma patient. Try not to give it to a patient you think might be suffering a pneumothorax. Try not to be giving it to somebody that has respiratory distress. It may not even be pulmonary. As you know, somebody with metabolic acidosis like a DKA may be acting like they're really, really air hungry because they're huffing and puffing, but their lungs are fine. So we have to do a careful assessment and think through our differential on all of our patients. But the vast majority of our respiratory distress patients are going to be in the category that's primarily pulmonary. Melanie?
One night, morning, I remember Alan and I read a patient who had, I believe it was a combination of throat and lung cancer. Do you remember him?
I think so, yeah.
More him feel better.
No, I'll be
He
darned.
could not breathe at all, and he didn't even strap it to his head. He just smashed it to his face, and it helped him. His vitals helped his general appearance.
So Melanie, for those that might listen to this later, is telling us of a patient that she and Tyler had that had throat cancer, lung cancer, and was in respiratory distress, and CPAP helped that patient's symptoms.
Yeah.
Yeah. So this, we don't know what the etiology of that patient's respiratory distress was, if it was upper airway obstructive or lower, but certainly.
I think it was upper, if I recall right. But yeah.
He didn't make it through the day.
Yeah. Well, you do no harm to those patients for sure.
And it definitely made his comfort level go way up, which decreased his stress, and then all his vitals leveled out. And yeah.
And a reminder, the protocol there will remind you all that it's an EMT basic, EMT intermediate, and paramedic skill. So this is a BLS skill. Really want all BLS and ALS providers to feel comfortable with it, know how it works, think about reaching for it early rather than late. It can really, really help us. It reduces the need for an invasive airway by a bunch. Yeah. And it helps people survive longer.
What about an anaphylactic patient that's not tolerating meds very well?
Great question. Tyler, do you have thoughts on that?
Yeah, so to repeat the question was, if you have an anaphylactic patient that's maybe the medications aren't working well, is that what you're, or taking a long time? Same opinion. You're definitely not going to hurt that patient, and you have an obstructive problem, and pressure is going to be helpful.
Yep.
All services in the RETAC around the time?
I know us and Monty, you guys are using the same one, correct? Yeah. I don't know.
One a little bit different. They use less oxygen. They have one that uses a little bit less oxygen than what we have. I'm pretty sure most of the rest of them have something similar to this.
Yeah, many of the, there are a whole bunch of manufacturers of these. I really like this system, but many of them are pressure driven. And actually pressure driven, meaning that they're volume driven in the sense that you adjust the PEEP, the positive end expiratory pressure, by turning up your oxygen flow, and they don't require, they can be used basically through the end of the regulator, and you can adjust it between 5 and 12 liters to get higher PEEP. And they do not use the volume of oxygen that this one does, but this one, of course, has the ability to give those very large FiO2s, and that's where you use the volume. Anyway, this is a really good system, and
I think
seems to
when
be user-friendly.
When you're running at the 30, then this is competitive with some of those other styles. But if you turn it up, then this obviously uses substantially more. Any other
All right,
questions?
folks.
Would CPAP be a good idea for a pediatric patient? I don't see anything as far as contraindications on the protocol. I mean, you got some big kids that are 10 to 12.
Yep.
They have asthma pretty good going.
You want to do this one or me? My take on it is there's no reason that a pediatric patient cannot use CPAP biologically. There is a very strong reason that they cannot use it behaviorally. You have to have a kid that's old enough and not panicked enough and comfortable enough to work with you to do this, because it really does take some coaching and some trust. And you know, our PEDS patients are going to be a little bit fearful without having to do some of that stuff. So to your question, Andrew, yes, it can be used in PEDS, but I would be thinking it would be more like the 12-year-old or the 13-year-old. Many manufacturers of the CPAP devices do make what they call a pediatric mask, and it's just a smaller version of this, but it's probably for young adolescents, and certainly worth a try.
Yeah.
Tyler, anything?
No, I agree. It's going to be, even adults can be pretty difficult to coach through this if they're not used to it. Fortunately, it seems that, at least from my experience, most of the time that we've used this, it's on a patient that already is experienced with CPAP, either uses it at night or has used it in the past, and that sure makes it a lot easier. But
All right, guys. Well, thank you. Appreciate it. Call it quits. Thanks, Tyler.
yeah.